Hi, and welcome to the next edition of the Academy by Acclivity Health Solutions. Today, we're going to jump into what should be your clinical focus as you think about value-based care. So in our last discussion, we talked about administrative focuses. And in this particular discussion, there really are two things that should sort of take your attention. The first of which is, how do you support the engagement in between visits, which we spent a good bit of time thinking through in some of our discussions we had previously around administrative focuses, where that was the core tenet, like doing the measurement of utilization, cost, quality, driving engagement between encounters. That's part of the model of care. The other model of care that needs to get your attention is the point of care clinician. So we really could split these up differently than we have. We could have just talked about model of care. But the reality in an alternative payment model, we always talk about Moneyball, the Brad Pitt baseball movie. If you haven't seen the Brad Pitt baseball movie Moneyball, it's great example of how an industry changed by changing its focus. They scouted by physiques, by throwing, running, batting. How you looked as a player became important when the reality was statistics was a much more deterministic sort of factor. That's what's happening inside of healthcare. So instead of us just thinking about like how we might have practiced for the last 30 years or 40 years, we really are thinking about how can we use data really to transform point of care clinician decision making. So we could have talked about model of care as a total thing. We really married them in Moneyball for medicine, which is if you focus on the data available to you, if you focus on the incentives inside of the contract, if you focus on the quality measures that are in these particular arrangements, you can succeed far greater under these new alternative payment models than you could have ever succeeded in alternatively under fee-for-service models. So that's been proven out for about 30 years in capitation states where delegation for risk is pushed down significantly on providers who have to take a PMPM payment methodology. Almost none of them in, say, California will take a fee-for-service patient today because there's no money in it relative to how you make money under managed care. So long setup for us to talk about point of care, model of care, and the clinical focus you need. This is a face sheet. It is often tied directly into the electronic health record. It's digitized, it's available, it's situationally aware, it's contextually aware. We often know in a patient who's happened to be, engaging me as a clinician in my Epic or Athena or Allscripts or Cerner EHR, these things need to be pulled from all this other available data and then made very simple and usable for clinicians at the point of care. So this is an example of one of those. And if your model of care isn't starting to think about, what are we seeing from the frequency of appointments? How much has this person had higher than expected utilization, or what's the history of this patient look like that's aligned to my EHR where I've documented encounter history with them versus misaligned? Often we'll see really sick patients disconnect, untether from primary care who has the risk for this patient because the daughter in daughter care is literally taking that patient already to an oncologist, a cardiologist, a neurologist, and primary care just gets dropped off because she can't do all of that, manage her own life and her children. So that's a problem if you're at risk as a primary carer. So we need to know what's been happening in the last 12 months and how aligned your perspective is by how often you're fed that and you're subjective and objective from the daughter who's sitting alongside the demented patient in your office. You need to manage risk scores. You need to be aware of important things that you can do things about, as well as being able to refer to appropriate levels of care that are often misidentified or missed altogether at the point of care. You also have to engage in some of the coding opportunities. So things that are falling off that are often not resolved until death are coding opportunities, which for this case would be more than 1/10 of a point of risk adjustment scoring. You need to know about medications that might have been filled away from you. You need to have understanding of what's happening relative to ED in other visits. And so this is a simplified version. I'm going to I think I have a more complex patient here. I'll scroll around if I see if I can find one really quick. Yeah, here's another example. So look at this particular patient. This is bordering on information overload. The reality of this particular case is the level of complexity this patient has had is significant. Lots of inpatient utilization, really high risk scores, Lots of things driving this person towards having an immediacy of care around you, not just at the point of care. So there's this intelligent sort of knowledge of being able to inform a palliative care consultation with this patient family. So they can get fairly complex. They'll start to look more than a page long. And again, this is only when you start to work patients in your panel that are sorting exceedingly complex over time. So this is a part of what you have to think about clinically. Like, how do I inform my clinicians at the point of care, aligned to this patient that's in front of them in that particular episode, tied off to the electronic health record where they should be working 99% of the time digitally. And then how do I ensure that those things are seamless and that we literally are making the lives of clinicians at the point of care both supported with clinical decision support, but easier than what they have been in the fee-for-service modeling. So we'll dig into this more in future episodes. If you have questions or want us to go deep on questions you might want to bring to us, please send them to info@acclivityhealth.com. See you soon.